I now call upon Dr. Chandrashekar WAVIKAR, who is going to talk about managing complications in flax.
Thank you, Nitin. Very nice presentations. And I'm going to start with Robogan Rouge, that is complications of flax. So it's a video throughout, but I'll be giving the comment. Now let us look at how a normal case of flax is done. It is very essential to have central docking, and that takes care of most of our problems. And then you adjust everything on the dial and also on the OCT, nucleotomy, capsulorhexis, nucleotomy followed by incisions. In most of the cases, when you have central docking, the incision opens very easily. It just takes 1 to 2 seconds, and after that, capsule is 100% cut in most of the times, and you have to just separate it with the help of visco. Similarly, the nucleus pieces, they are very well dissected. We just need to mechanically separate them. The amount of force required for separating is much less than what you require for chopping. Now let us look at the complications one by one. Most of the times when the patient is anxious, okay, or you have a small palpable pressure, you have eccentric docking. Now eccentric docking, you can have a problem with placement of the incision, placement of the CC. You can see that the nucleus is appearing tilted. It is not tilted, it is because of eccentric docking. And capsulotomy has to be placed very well, but we are getting lot of time to adjust, and lot of parameters are there. Second, next complication which used to get previously, now with the introduction of PI, it is not there, and that is air bubble during docking. This we find more commonly with RK patient with very flat corneas, and many times we have to redock. Uh, then sometimes there can be corneal folds. Again, this is an unexplained thing. The software PI is very good, but you do get these folds, and because of air bubble or whatever complications we have explained before, we have to complete a capsulorhexis with the help of a forceps. So wherever the folds where you can see that there is a tag attachment attached, and it has to be separated. Now there is one interesting surgery we'll like to show, and it was a 72-year-old lady. I started doing flax, normal case, everything going smoothly, incisions opening properly. Hydrodissection, I don't do hydrodelineation, and after injecting visco, I started doing phaco. Phaco also was very, smooth, no doubt of any problem. You can see even in the grade 3-4 cataract, separation of the pieces is very, very easy. And then cortical wash and then implant. So basically what went wrong? It appears that everything was very, very smooth, but however the patient had a very, very cloudy cornea, and it refused to improve, get clear. And that is where we decided to look at the video again. So let's rewind. There were enough telltale signs, but we were just blind to it. You can see that I am just dissecting a membrane out here. This is sign number 1. Now, if you see the air bubble on the extreme this side, our left hand side, you can see that the configuration of the air bubble is not correct. So as if there is some membrane in between. Again, same sign, okay. So basically what I had done is that I was doing all the maneuvers above the Descemet's membrane. And you can see that the membrane is there. And now I have taken the rexis, and now you can see I am taking another membrane. Okay, but it was so crystal clear that I did not have any doubt. Of course, patient had to go ahead with DSEC, and that is when we started observing our surgery videos more carefully for whether there are any signs. And you can see, even in a case where we did not have Descemet detachment, there are signs. Luckily, these complications are very few. You can see one air bubble over here, that arrow. Similarly, there is one more air bubble over here. We call it immobile air bubble sign. It's because if you see, those two air bubbles are constantly present, this one and the second one, throughout the surgery. So you can do all the maneuvers, it will be present. Basically, that is the air bubble in the pre-Descemet's area. So I will take two separate side ports. And ensuring that that area does not get touched at all, or even the fluid does not go there. I completed the phaco gradually, and even during IA and lens implantation, those two air bubbles are there. Essentially, there was a problem with the layer separation and the energy size, and once we sorted it out, this problem disappeared. Of course, it's not happening too often, but it did happen, 3-4 cases. Now you can see that I am overhydrating in an attempt that the air bubble becomes smaller. I am even hyperinflating the antechamber, but the two air bubbles still remain. And that is where we started to decided to have a careful look at the literature. So it is a real-time OCT to understand what is the incidence of Descemet membrane detachment during cataract surgery. And to my surprise, the incidence of DMD is almost 94%. That means in every patient we are getting. And out of that, 80% of the time, anterior as well as posterior, both the lips are getting detached. Only very few cases, it's either upper or lower, everything is getting detached. Now, the last moral of the story is that it is always there, but we have to be careful while introducing the instruments and look for signs whether anything like this is happening. And if we see immobile, of course, it does not appear in a normal cataract, but at least in flax, we can see that sign and take corrective action. Now, the last complication is not per se a complication of LenSx, but it does trouble us sometimes. That is the registration failure. That is the virion does not register. There are many reasons: arcus senilis, mature cataract, improper illumination, etc. And once we do this, we get more registration. Even then, the incidence of registration failure is around 5%. This is the only thing which is kind of bothering.